Friends, in this video we'll discuss the sciatic nerve, some of its branches, and a clinical application of the innervation of some of the sciatic nerve branches. Start out here, the piriformis muscle. We're familiar with that one. Inferior to the edge of the piriformis muscle, we have emerging the sciatic nerve, one of the largest, and some people say the largest nerve of the body. Sciatic nerve proceeds down the posterior thigh and then divides just above the popliteal space into the tibial nerve and the common peroneal nerve or common fibular nerve. Tibial nerve proceeds inferiorly between the head of the gastrocnemius down the posterior leg and passes parallel to the posterior tibial artery and vein down to the medial malleolus. Passes around the posterior aspect of the medial malleolus. That's the tibial nerve and the posterior tibial artery and vein. If you come up again to where the sciatic branches into the tibial and then the common peroneal or common fibular nerve. Common peroneal nerve comes inferiorly and then passes laterally around the head of the fibula. Here's the head of the fibula. And common peroneal nerve passes laterally around it and innervates the muscles of the anterior lower leg. They would be the tibialis anterior, the extensor digitorum longus, and extensor hallucis longus. These three muscles dorsiflex the foot or lift the foot as we're walking. Let's say, for example, clinically, that you've got a patient in the operating room, you've got their legs up in these gutters so that you can operate on the rectal area, and the legs are lifted up out of the way. The legs are put in what we call gutters or stirrups, and if you don't have plenty of padding between the lateral aspect of the head of the fibula and the gutter, then this nerve, the common peroneal nerve, will be compressed between the steel gutter and the head of the fibula, and over a 4 or 5 hour operation, that nerve will be completely destroyed if there's too much pressure on it at this point. The patient then is no longer able to exercise these muscles. These muscles become atrophic, and the patient suffers from what we call foot drop. In other words, as they walk, they have to raise the knee extraordinarily high in order to avoid tripping on their own toes because they can't elevate or dorsiflex the foot.